Everyone. Welcome to the third AIR rounds, where we look at two incidents from the previous month's newsletter, which will be presented by the APSA ambassadors and later followed by a discussion amongst all the participants. It's indeed an honor today that we have senior anesthetist with us. Professor Badrinarayan sir is here, who is the head of the Department of NIMANS and a very, I would say, prolific researcher, academician, and also an administrator. We also have senior physicians, Dr. Nalini with us. Of course, Sunil Pandya sir is here. And I can see even Dr. Shishir having logged in. Today, we also will be discussing very interesting two cases which have been reported in the anesthesia incident registry on our doc tab. And before we start the proceedings, I request Dr. Abdul, who is the developer of the doc tab. He wanted to say a few words before we start the entire session. So, Dr. Abdul, would you mind just speaking what you had in your mind, please?
Good evening, sir. Thank you. Good evening, Sunil Pandey, sir.
Good evening.
Sir. Yes, so what we'll do is last meeting we couldn't conduct this exercise. What we wanted to do is test the server load that can be taken up at a time. So we want to conduct that small test. For that to happen, what I need is for all the users or for the attendees of this webinar that you think of a small incident or an event which might have taken place at your in your operation theater or your ICU or during the patient is in transit during PC or any other event. It might be as small as not labeling of a syringe or an inadequate dose administered to the patient. It can be as simple as that and any other event. Just think of it and download the app if you have not already downloaded it. And after these two presentations are completed and our discussions, we will assign 5 minutes of our time so that you can log it. If at least 50 to 60 users are using the app at the same time, we can just understand what load the server can take. And this is a small test that has to be done from the backend team. So think of a small incident and we'll take this up again at the end of the session. Thank you. Thank you.
Yes. One more thing, Dr. Murli, before we start, I am getting direct messages from many reviewers, experts. I think they are not getting notified when the case is reported. And still, I think the know-how about using app, I think we need to have one session exclusively for experts. I got at least 3-4 people that direct message me directly about this. So I think we'll at some point of time we'll plan again using this app and how to review and how to give the comments.
Sure, sir. Thank you.
Thank you.
Before we start, I request everybody to kindly mute themselves and only the speaker to be unmuted. So over to Dr. Archana, please.
Hi, thank you so much, sir. Hi, Sunil Pandya, sir, and all the senior anesthesiologists present here today. It's my delight to introduce the two speakers, enthusiastic anesthesiologists who are going to present our cases today. So first up, we have Dr. Sachin Bharadwaj, who is currently a consultant anesthesiologist at Bhagavan Mavi Jain Cancer Hospital in Jaipur. And also our second speaker today is Dr. Amrita Nair, who is currently working as a consultant anesthetist in the Madras Medical Mission in Chennai. Okay, so I will hand over quickly to the speakers so that they can start presenting, making their presentations. Over to you, Dr. Sachin. I believe you're going to start today's session.
Thank you so much, ma'am, for kind introduction. And
As Sachin is sharing the screen, I would like just mention the chat box is active. So if people would like to kind of put out their comments as the presentation is going, any questions, please feel free. It's a very informal, interactive session that we would like to have.
Just a minute, sir. Okay. Let me
Sachin,
try.
Sachin, we were able to see your screen. It was very good, actually. You could have just started.
Oh, okay, okay, sir.
Yeah, you can just
But
share
I
the
was
screen.
not able to visualize. Yes, sir.
And
So, good evening, everyone. Today, I will be discussing clinically important intraoperative complication, which is usually under recognized and reported. And it was published in last newsletter in by APSA. So it is a case-based exploration of three clinical issues regarding diagnostic anchoring and physiological masking and life-threatening consequences of delayed pneumothorax recognition during laparoscopic and robotic surgery. So let me start with a clinical trigger. During laparoscopic surgeries, uh,
Sachin, we're able to see the slide. You can carry on.
yes, sir. Yeah, but I'm not able to see, sir. Actually, there is some problem.
See,
Can I stop sharing, sir, and rejoin again?
no, you just go down to your PowerPoint. Your PowerPoint is where you are going to be seeing your slides and just carry on. You don't need to see anything else.
But it is showing in a small icon, sir, actually. Okay, okay, sir. So during intraoperative surgeries, yeah. So during intraoperative surgery with strip Trendelenburg positioning, pneumothorax developed intraoperatively. Rising airway pressures were initially attributed to positioning and pneumoperitoneum, which delayed recognition. Hemodynamic compromise subsequently developed, and diagnostic anchoring to a positional etiology and delayed exclusion of barotrauma were identified as a key contributing factor. So it was a case which was published in last uh, April newsletter, and the core concept behind this case was diagnostic anchoring bias. When I go into detail of this terminology, diagnostic anchoring bias, I realize that it is it has a similarity. It reminds me a scene from a movie of PK, during which the Amir Khan said to Anushka that Tapaswi has fed some wrong information in his mind, in her mind. So here we, if I consider the Tapaswi as a uh, physiological, uh, physiological bias, and the wrong input as a Trendelenburg position and pneumoperitoneum, then it become a diagnostic anchoring bias. Mean every time when we want to reach a diagnostic, like pneumothorax, but the increased airway pressure due to positioning and pneumoperitoneum keeps a continuous wrong number in our mind. So moving on, what is this physiological trend? Mean what was Tapasvi feed in our mind? So the physiological trap is that when the surgeon create a pneumoperitoneum and there is a steep Trendelenburg position, there is always a diaphragmatic shift and decreases the functional residual capacity and decreases lung compliance and it increases the airway pressure. And it is beautifully explained in this BGA journal that these all changes during laparoscopic and robotic surgery establish a physiological baseline that obscure pathological deviations. So how frequently these incidents occurs? So when I go through these two articles, one by Murdoch et al., they they suggested that they uh, identified 9 out of the 968 patients who are undergoing laparoscopic surgery. The incidence of pneumothorax and pneumomediastinum was 1.9%, and it was just due to prolonged surgical manipulation and large amount or presence of CO2 gas insufflation. So basically, the high risk categories, high risk surgeries are robotic surgery, might be prolonged steep Trendelenburg position and prolonged procedures. Next, another article, Pizzo et al. Concluded that they identified in 1,765 patients out of 1,765 patients who are undergoing laparoscopic renal surgery, only 10 patients, 0.6% intraoperatively experienced pleural injury that subsequently lead to pneumothorax. So the incidence is low, mean 0.01 to 2%, but still the consequences are relatively very dangerous, mean I can say lethal. So out of the barotrauma or CO2 pneumothorax, or we can say capnothorax is much more commonly reported. So let's uh, identify what is the core pathology behind this. So the core pathology are two pathological aspects and one outcome. One outcome is pneumothorax and two pathological, like it can happen due to barotrauma or due to CO2 intraoperatively, which I can say capnothorax. So in barotrauma, there is a high airway, because of high airway pressure and alveolar distension, the air tracks into the pleural space. While in CO2 capnothorax, CO2 pneumothorax, when the surgeon creates a pneumoperitoneum, the CO2 escape from the intraperitoneal cavity to the thoracic space by either esophageal hiatus or congenital diaphragmatic hernia, congenital diaphragmatic defects, or iatrogenic injury to diaphragm during liver or laparoscopic hepatectomy or cholecystectomy. So this CO2 tracks into the pleural cavity and develop the capnothorax. So more chances are developing a capnothorax, but capnothorax is much manageable by the conservative management because CO2 is highly soluble in blood and it rapidly absorbs across the pleura and eliminated by the respiration. And here, when I go through the articles, it shows that capnothorax is more likely, it doesn't related to the steep Trendelenburg position. It occur still in reverse Trendelenburg position because capnothorax more likely occur in the right side during laparoscopic cholecystectomy or hepatic surgery because of surgical exposure of omentum, which naturally cover the diaphragmatic defect or weak points. Like if a patient has a congenital diaphragmatic defect, so the omentum cover that defect. But during laparoscopic cholecystectomy or hepatic surgery, we explore the momentum. That's why the defect uh, become open. And second thing, the surgical head up position, mean we can say the reverse tendon position. So in the reverse tendon position, this CO2 gas insufflation may increase the risk because the position may push the lever and momentum downward. That's why it exposes the diaphragmatic defect in pressurized abdominal cavity and it develops the capnothorax. So what are the early signs when we have to act on? So unexpected deterioration beyond expected physiology always raise a suspicion of pneumothorax, mean pathological, any pathology, like sudden airway pressure, sudden decrease in SpO2, sudden hemodynamic instability, or difficulty in ventilation. So we should not anchor during laparoscopy on pneumoperitoneum and position of the patient. Increased airway pressure should be uh, diagnosed in a stepwise manner. So we have to rule out endobronchial intubation, we have to rule out any secretion, bronchospasm, we have to rule out any circuit issue, and pneumoperitoneum also, and then pneumothorax. So do not anchor on step 4, mean pneumoperitoneum effect, as a diagnostic of exclusion. So what is the diagnostic tool which we have in our operating theaters? So right now we all know that point of care ultrasound. Everybody know that lung ultrasound is a key diagnostic tool intraoperatively in operating rooms because we cannot shift the patient to the CT scan, or we have facility of bedside chest X-ray, but it is time consuming. So lung ultrasound is much more time efficient and better for diagnosing a pneumothorax in emergency cases than bedside chest X-ray. So what key features are there? There may be a absent lung sliding. There may be a stratosphere or barcode sign. Mean the normal seashore sign may be absent. There must be absence of B line. So what does the sonography is highly suggest of pneumothorax because it has a 95% sensitivity and 100% negative predictive value and 87% positive predictive values. So how can we manage if one uh, identified the capnothorax or pneumothorax intraoperatively? So first, you have to inform your surgeon for all cases. You have to inform your surgeon, you have to reduce the insufflation pressure, and you have to reduce the angle of the table and administer 100% oxygen and check the airway. Mean if there is any tube problem, mean endobronchial intubation, circuit problem, any any like airway problem. So once you identify, you rule out all these things, you have managed all these things, then if your patient is stable and you have identified that this is capnothorax, then you're gonna do as a conservative management. So because CO2 is rapidly absorbed, so just apply a moderate amount of PEEP, 4 to 6, and close monitoring. If your patient is unstable and tension pneumothorax, and then you have to do an immediate intervention, like you have to decompress the patient, thorax with needle insertion, or you have to put a formal chest drain. So, and if your patient is unstable, like hemodynamically not stable, then you can use a vasopressor support also. So prevention is better than the cure. So always modify the risk factor. How can we modify that? We can use lung protective ventilation. Even you can choose a low tidal volume and moderate amount of PEEP, 4 to 8 centimeter of H2O, and specifically pressure controlled ventilation may improve gas exchange and reduces the risk of barotrauma through more uniform alveolar inflation. And you can limit the insufflation pressures and avoid extreme trend lane position. One thing I have to mention here that point of care ultrasound, it reduces pleural injury risk at every step, like from from looking central venous access to intraoperative diagnosis. So ultrasound for central and real-time ultrasound guidance for subclavian or internal jugular vein significantly reduces iatrogenic pneumothorax. So my take-home message is that what we have to recognize intraoperatively what is normal and what is dangerous. So think out of box. Just don't think that we have given the patient head down and we have created a pneumoperitoneum. So rise in airway pressure, it will be happen. I mean, it is normal physiology. So you have to think that if there is a rise in airway pressure suddenly, and uh, then it might be a pathological. So suspect early and scan immediately and act decisively because unexpected deterioration beyond expected physiology always warrants an attention. Thank you. Thank you, sir. Should I stop my sharing?
Yes, please. Yeah. Thank you. So I request everyone to comment or post your queries on the chat box. We will take it at the end. Archana, do you want to?
No, so actually, I always have this doubt, as to when they have a steep low, how steep to go. And I mean, they say for robotic surgery that you almost go 180 slant. So it's always a doubt for me. It's very eye-opening how your presentation. So thanks very much. We can just open it to the
Yeah.
who have experience and who have seen the issues that happen.
Can I, Archana?
Of course, sir,
Yeah.
please.
Thank you, Sachin. It was a lovely presentation of the case incident that was reported. But more importantly, yes, the capnometer, that is the insufflator, and the position of table is solely managed by a technician who knows nothing. And they always look at the comfort of the surgeon, not the patient and not the physiology. So, a request for every anesthesiologist that the insufflator pressure, the intra-abdominal pressure monitoring is the additional monitor that we need to keep an eye during all robotic and laparoscopic surgery, which we tend to ignore. Because if you see some of the surgeons, the moment they put a Viris needle, the flow rate is by default set at 15 liters per minute. Okay, Viris cannot give more than 5 liters, but why do you want to keep 5 liters also? When you're putting a Viris inside, start with 1 liter or zero point 0.5 liters and slowly escalate it once you confirm the tip is in the peritoneal cavity. But by default, the technician sets at 15 liters, it is set at 15 liters per minute. That is one thing. Second thing is by default, so that at least the beginners of laparoscopic surgeon, the intra-abdominal pressure is set at 15 millimeters of mercury, which is not the case. It should not be done. In fact, if the abdomen average build patient 10 to 12 millimeters of mercury pressure suffices. Yes, when you're putting a trocar, a novice or a beginner surgeon, they may require a little higher pressure. But once the trocars are in, you can just come down to 12 millimeters of mercury or 10 millimeters of mercury pressure, which is quite significant. So you don't have to go for default values. You need to tailor make the insufflation to tailoring to the patient physiology. And as Archana asked, how low, how deep renal bucket? Again, as I said, that has to be again controlled by the anesthesiologist in concurrence with the surgeon. Yes, when the surgeon is finding difficulty, the bowels are coming in the way, then you can always give. But once the surgeon is comfortable, you can always make it at decent level, about 15 degrees, 20 degrees, most of the time suffices. But by default, as you rightly said, it can go up to 180 degrees, and the patient almost slips out of the table if there are no shoulder support blades. So positioning is very important. One more thing that I learned from our experience is One of the easiest way to diagnose is, of course, falling ETCO2 trace. But importantly, ask the surgeon to focus the camera on both the diaphragms. So the diaphragm is stunned if there is pneumothorax. So that side of diaphragm doesn't move. And similarly, it can happen in endobronchial intubation also. But most of the time, if the endobronchial intubation is ruled out by bilateral equivalent entry, then it is just that the stunned diaphragm, which is seen through the laparoscope, is the easiest and the earliest and the fastest way. And of course, focus comes much later. But I think ABCs are very important. Other important is, yes, it goes along the esophageal hiatus, perivascular hiatus, but the pleuroperitoneal remnants in the diaphragm. Like if you look at the embryonic development of the abdominothoracic cavity is a coelomic cavity, and slowly as the embryo advances and the fetus advances, it segregates into diaphragmatic cavity and the thoracic cavity. I mean, peritoneal cavity and thoracic cavity. So there are certain pleuroperitoneal remnants that are closed under normal physiology, and whenever the intra-abdominal pressure increases by for any reason, it could be laparoscopy, it could be pneumoperitoneum, or it could be intestinal obstruction, or it could be sometimes we see sudden diaphragmatic eventation for whatever reasons. So whenever the intra-abdominal pressure increases, the pleuroperitoneal remnants they open up, and then you see this pneumomediastinum, which can be more dangerous. You can end up with selective pneumomediastinum and can go into the neck emphysema, or sometimes pneumothorax as well. And yes, hemodynamic unstable patient, you may have to put ICD. But if you put an ICD, it will be difficult for the surgeon to complete the surgery because the gas forms a route to escape. So you need to balance. Most often, reduce the pressure, stop the surgery for a while, and then operate at low pressure and keep titrating, keep monitoring. And worst scenarios, you may have to convert it to open surgery. So do not compromise the patient's safety. More importantly, in a robotic surgery, uh, undocking itself is an exercise. So you need to do mock rehearsals and mock things. So if you want to really undock the patient from the robotic instruments and panel, it may take at least 15-20 minutes if the team is a new team. So you need to make sure that you do these exercises routinely, the mock undocking of the robot from the patient, so that if the resuscitation becomes easy. So these are the few things that I wanted to share, Rachana.
Point noted, sir. Thank you so much. I'd request any other faculty member if they wanted to add something. Murli, sir?
Yeah, I had come across one case when way back in the UK, patient was a day case surgery, laparoscopic cholecystectomy done and sent home. Patient developed pneumothorax at home, was rushed to the emergency, and of course, there's more of morbidity rather than mortality in this case. But it was the first time when I became aware that when after going home, patient can develop a pneumothorax. So that's the point. But as Sunil sir rightly mentioned, all the points that he mentioned, especially for all the juniors here, main thing is you have to act fast when there is a pneumothorax. That would be the message. Because if you wait and if you're not sure what you're doing, then it can be catastrophic. Badri Narayan sir is here. Badri sir, welcome to the AI rounds. Would you like to say anything on this case?
Good evening, Murli. Thank you so much. I just want to add that what Dr. Pandya said is very important. Just have to tell the surgeon to focus on the diaphragm, because if he's able to see the movement, that will be a first indicator. We will catch it very early. Instead of mobilizing an ultrasound, directly if we can focus the scope on the diaphragm, that will clearly tell us, and we will also be able to see if it is moving or not.
Yeah.
Of course, we'll have to depend on the other parameters which we would be monitoring. Like he said, it's very true that intra-abdominal pressure of 10 to 12 is normally enough. Maybe when beginning as there, they probably want about 14, 15. But the safe level is about 10, 12 millimeters of pressure. That should be enough.
Yeah. Thank you, sir. Thanks for your inputs. Archana, can we carry on with the next presentation?
Yes, of course, sir. So we have Dr. Amrita next, who is going to discuss another very devastating kind of a complication. Dr. Amrita, would you like to start?
Sure, ma'am. Ma'am, can I be allowed screen sharing?
Yes, of course. Yeah, Murali sir, is she able to share?
Yes, ma'am. Now I can. Good evening. At the outset, I'm Dr. Amrita. I'm a consultant anesthesiologist in the Madras Medical Mission, Chennai. And I'm extremely grateful to Dr. Murli sir, Bala sir, and Sunil sir, and all the other senior anesthesiologists who have given me this opportunity to present in the AI rounds today. So I'll be talking to you about one incident that has been used. Just a second, I'm not able to move my slides. Yeah. So this is the incident report that was published on the April edition of APSA newsletter, in which there was a devastating error that had happened during an emergency lower segment cesarean section performed in the night, where neostignum was inadvertently prepared in place of bupivacaine for spinal anesthesia. And the same was administered to the patient as well without verifying the injection. There is another incident report on similar grounds as well, wherein erroneous drug was injected into the intrathecal space, and the patient had devastating life-threatening complications. So what we understand from these two incidents is that there are drugs which are looking alike and sounding alike. And these medication errors are the leading cause of patient harm. Most of them are inadvertent. And the Global Patient Safety Challenge of WHO goes with the caption medications without harm. So what are look-alike medicines? They are basically having orthographic similarity, which means the containers of the medicines look similar. And what are sound-alike medications? Sound-alike medications means they have their names have phonetic similarities, which means their names would look similar, would sound similar. So what is the scale of LASA? LASA means look alike and sound alike, right? So what is the scale of LASA errors? They account for about 6.2 to 14.7% of all medication errors. And prevalence is as low as 0.0003% to 0.002%. And they account for nearly 7% of medication near misses. But LASA are difficult to quantify. Why? Because the manufacturing trade names keep changing. The packaging keeps changing. There are newer medications in the market from different manufacturers, and there is changing formulary in individual hospitals. So all this makes quantification of LASA errors as difficult. And what we see on the publications and on the scientific forum is just the tip of the iceberg. And there is a lot more that is happening in actual reality. So what they have found in many case reports is that incorrect dosing and medicine substitution is the leading cause of medication errors. So the primary contributing factor for substitution is look-alike drugs. And almost 44,000 to 98,000, almost a lakh patients annually as a result of medication errors, which is quite high. So these have been some of the published cases of LASA errors, wherein midazolam was injected into instead of midazolam, a patient was injected vecuronium just because the containers were similar. And there have been instances where IV acetaminophen and paracetamol have got interchanged, succinylcholine and ephedrine have got interchanged. So all of these can be catastrophic and fatal and cause mortality to the patient. So common lookalike errors other than these which can occur are cardiac medications that get administered intrathecally, like tranexamic acid, digoxin. These can all cause encephalopathy, paraplegia, and status epilepticus also. So there can be incorrect visual inspection of the lookalike ampules, which common these. Prevent these, because every life that comes to us is precious and important. So there have been recommendations from the Joint Commission and the FDA which identified LASA errors as a major focus. So there have been efforts through education and tools to reduce the risk of these errors. Joint Commission recommends have their own set of recommendations, some of which I have mentioned here, which includes each hospital to have their own list of LASA medications rather than downloading one from the internet or using something that is already ready-made by some other forum or some other hospital, so that each hospital can have their own set of medicines, which is unique to each institution. And these lists have to be reviewed and updated annually so that the formulary keeps updated. What FDA recommends is Stallman lettering. What is Stallman lettering is where the uppercase letters are used for the portion of drugs which look similar. For example, we commonly use both dexamethasone and dexmedetomidine in our anesthesia practice, and the names are almost similar. And if we use short forms, it might get even more confusing. So on the drug labels, the methazone portion and in dexmedetomidine, the TOM portion are labeled as capital letters to make the identification easier. FDA also has developed various computer software analysis to identify orthographic and phonetic similarities in developing brand names. So that can help the future manufacturer going to manufacture new drugs. The prevention steps have to be taken at various levels, right from the development of formulary of the institution, from the stocking, from arranging them in the drug trolleys, from the time of administration. Everything has to go through rigorous checks and measures. So where we can avoid using abbreviations and use full names, either the generic or the brand names. Avoid purchasing drugs in which the manufacturer logo is larger than the medicine name. And the names have to be double checked before they are admitted into the hospital formulary, so that errors can be prevented. And brand names and generic names should be displayed along with the problems for which they are used for, so that they prevent drug errors, especially for lookalike drugs. And we can develop order sets with indications for problematic drugs. While administering, we have to read the name of the drug loudly from the container and or the pharmacy label, and not to rely solely on a partially turned pharmacy label. Do not rely on the color of or container cap or company graphics and take for granted the name of the drug. When we stock or store the drugs in the trolley, organize in a label up rather than in a cap up position. Avoid proximity of drugs that look alike and sound alike, and avoid particularly cap color similar drugs. Here, if you can see in the image, both the drugs have blue caps, but they are different drugs. All three drugs have green caps, but they are different drugs. So we can avoid stacking these drugs together. So this is a preventable threat to a conclusion. To conclude, this is a preventable threat to patient safety, and multiple strategies have to be used at each level to prevent these medication errors. Again, in the picture that I've posted here, as you can see in the circle, there is a small arrow on the label of the drug so that it helps in identifying succinylcholine and phenylephrine separately, though they look similar on the preloaded syringes. So multiple strategies have to be used at each level, right from the manufacturing till the drug is administered to the patient. So the top-down strategies for avoiding new look-alike, sound-alike drug names should be developed so that future development doesn't have these look-alike and sound-alike names. So what is the 5 rights framework is right drug, right patient, right dose, right time, and right route. So all these 5, if we follow meticulously, we can bring down the incidence of LASA errors to a greater extent and make the anesthesia safer for most of our patients. Thank you. And please do not forget to log in your experiences into the Doc app, which is available on the Play Store and the App Store. Thank you.
Thank you, Dr. Amrita. That's a very, very good presentation and very highlighting the very importance of these look-alike, sound-alike drugs.
Thank you, ma'am.
Yeah. So, I mean, yeah, I also had a similar. I didn't have a similar thing, but one of my colleagues had a unfortunate incident like this where he had administered it for a cesarean section. So the most common one is tranexamic acid most of the time,
Yes.
especially years ago it was. So it was administered to his own sister, and in the middle of the night, and she ended up passing away. So it's a very devastating complication which can be simply avoided by just cross-checking the drug and whoever is the person administering the drug, how many ever times it is checked. The final check has to be the person who is aspirating the drug, who's breaking the ampule. Have it even verbally out. So what I like to do is I like to run it, have it in the tray. I have the technician or whoever is handing me the drug. I have them read out the date. I have them read out, what is the drug name and the date of when it's manufactured and the expiry. And then only I also then physically look at it and do it. Every single time I'm giving a spinal, I make sure I do this and I try to ensure that my junior, whoever is doing that as well. So closed loop communication is also very important in these kind of a scenarios. And the person who's administering should be the final check to what this is. So Murli sir, Sunil sir, would you like to add anything else?
Yeah, before I comment anything, I request everybody here, there are 64 participants. Is there any tip that you use? Anything like, a clinical pearl from whatever you have learned from your own experience? If you can share it in the chat box, that will be more like crowdsourcing, tips to avoid drug errors. So it's been a very silent group actually. Nothing in the chat box yet. So if people can just type in one small tip that you do to avoid LASA related errors. So whatever it could be, however small. So we would like to know. In the meanwhile, we can have Sunil sir, if you have any comments about this, please.
Yeah, one thing, if you see, since the time the tranexamic acid came as a protocol for PPH prevention, 2014 onwards, there are at least 94 case reports worldwide of inadvertent intrathecal tranexamic acid. So one thing that we do in our hospital is do not store tranexamic acid in the theater or in the theater trolley or in the theater. Let it be in the pharmacy, and whenever there's a need, it's not an emergency drug that has to be given within 5 minutes or 10 minutes. You can always procure it. It takes about 10 minutes from the pharmacy to dispense the medication. You can always administer. So first and foremost is do not store tranexamic acid or lookalikes medications that are not necessary and that are not dire emergent. Second things, there are similar case reports where potassium chloride has been injected intrathecally and epidurally. Similarly, so potassium chloride also is not an emergency drug that has to be administered to correct hypokalemia intraoperatively. So generally in our hospital, the pharmacist dispenses the potassium dilution and then gives us the diluent fluid. But there is another thing that you need to do. So do not keep unnecessary medications that are not necessary in the theater or in the emergency crash cart. Second important thing is, as Archana rightly said, rule of three. The anesthesia technician reads out the name loudly, and we read out loudly, and then we load. And before discarding again, he reads. So at least about rule of three or rule of four, you're reinforcing each other so that you've loaded the right. He has picked up the right ampule. You would read and load the right drug, and before he discards, again reconfirm that okay, same drug has been loaded. And always have a habit of inspecting the discard tray, as we do in the code blue protocol. Once the code blue is called off, we always look at the discard tray so that the right drugs were given, because during crisis, during emergency, multiple people are helping you out, and during loading, and you may inadvertently load wrong medication. So certain ground principles, certain ground policies are very, very important. Come whatsoever may happen, do not compromise on rule of three. If you look at the types of drugs that have been injected neuraxially, halothane in 1970s in the UK, EPN has gone in. Chlorhexidine has been injected. Saline or distilled water, soda bicarb, diclofenac, tranexamic acid, digoxin, and as Amrita said, muscle relaxant. So many drugs have been injected. And yes, the damage control, there's nothing you can do. They have mentioned that saline CSF lavage, high volume CSF lavage, to an extent helps, but again, it is inconclusive and it is not possible in all times and all cases. So prevention is the best strategy.
Thank you, Sunil sir. Yeah, in fact, we have got some wonderful tips already. I thought I'll crowdsource, but it's actually very interesting. Dr. Vanilla has actually mentioned twice that yes, color-coded labels, reading loud and repeating, and using magnifier glass to check small letters, because some of the ampules and the vials that we're getting, it might be too small, especially as we have crossed 45, it can be much difficult to read. So using that is very important. Then again, Yogesh had a wonderful, again, reiterating the triple check, once while taking the ampule, while breaking the ampule, third while throwing the ampule. So fill only one syringe at a time and break one ampule at a time. Wonderful point. And Dr. Niveta again said, yes, double check the drug name, expiry, because that's another important thing, because you can have an expired ampule sitting there. So, and even if it is checked by a technician, and make them read it out loud, before, especially for spinals. And Dr. Vanilla again said, please come early, check all the drugs. So, you're not coming in late and then ending up doing something wrong. And in emergencies, allocate the job and double check with a nurse tech or a junior. Ultimately, we are responsible, rightly said. Dr. Barka said that yes, anesthesia technician can take a picture of the drug and zoom in if it's not seen very clearly. Wonderful point. Then somebody who's Oppo F29 says, check bupivacaine and buprenorphine vial again sound alike, look alike drugs, need to be careful. To retain all the ampules which are there, Dr. Niveda. And Viral says, yes, check everything before giving once again. So what I would like to highlight here is one aspect of decision making. There is a wonderful concept on decision making, which is called the decision making triad of a haircut, a hat, and a tattoo. So all of you might be wondering what this has to do with spinals or ampules. But if you see the decisions that we make in life, some of them are easily reversible, right? Like wearing a hat. You can wear a hat, if you don't like it, remove it, and then you can wear another one. So these are immediately reversible actions. There are some which are relatively irreversible. So having a haircut, so you went and had a very bad haircut. Yes, it will grow back, and probably in a week's time or 2 weeks' time, you'll be back to normal. So these are relatively reversible. But people who had tattoos done, I'm sure many of you might have had tattoos done in the heat of the moment, but then probably wondering how to take this out. So these are the tattoo kind of decisions. So when we give a spinal anesthetic or any drug for that matter as an anesthetist, we are doing these tattoo kind of decisions. And this was reiterated again by Jeff Bezos in one of his newsletters to his Amazon team, that when you open a door and it's actually an irreversible decision, be very careful when you walk through that door. So I would say that when we give drugs to patients, these are the kind of doors that we are walking. We are walking through highly reversible doors. Tranexamic acid in the spinal is a truly reversible door. And many such things like, giving potassium instead of something else, IV, or various things that we might have kind of come close to doing, but we might have heard people dying. So we need to be extremely careful. And these two incidents which have been reported today are real incidents. Please mind that these are not fictional things or something from elsewhere. These have happened in India. These have happened to our colleagues. And for somebody who has had this kind of incident, the second victim is the anesthetist. So that's something that we forget many times. So, we need to be very wary of all these things. And I think if Badri sir is there, I would like to hear his thoughts about this. Badri sir, are you here?
Yeah, I hear about it.
Yeah, can you just add a few words on this, sir?
Really, the first thing that I want to say is that we have to increase awareness about loss and death. If you just take a survey, I think about 60 to 80% of the anesthesia people will not know what loss and death. Because I have spoken to postgraduates, none of them seem to be aware what it is. There is no awareness because the pharmacist knows it, but many of the people won't know what it is. In the pharmacy, they'll maintain everything, but we have ensured that is one thing NABH does. If your institutes are NABH accredited, they ensure that you separate all the drugs in cupboards, so even in the OT. So that is one way of separating them. Second thing is, like old timers, we have to read the label ourselves. And I shouldn't say this now, but I don't know how much of supervision is there when persons are giving regional techniques. We have to ensure a senior person is there at the time of giving an anesthetic. We shouldn't walk in when they have trouble. We should be there from the time the patient is cleaned and raped. So these are all times where small things we can pick up. We must ensure that nothing that is not required should be in the vicinity of the patient at that time. I don't know how many people have drug trays in their OTs for anesthesia. I have ensured that all OTs have drug trays and only our people use those trays. Label them, keep them. If there is anything left, discard it. Don't keep anything because you don't know which person will come and take what from your care. And the other thing that I would want to say is that those figures of 44 and 98,000 is from 1999. The official figures of the Institute of Medicine in 2015 was 2.5 lakh medical errors per year. Deaths from medical errors. It's very high. Hospitals are very, very dangerous places. We have to tell our people that hospitals are very dangerous places. In the same report, they said 1 in 300 patients who enters hospital will die. So if your volume load is very high, the death rate also is likely to be high. And we have to ensure that some scrutiny is there because many times things slip through. Because especially at night when people are tired, it's just that you have a senior, probably the resident probably will come and tell you that we have a case which is coming up, and he probably say get everything ready and I'll come, and he may not go. We have to be accountable to ourselves. First thing is we have to be accountable because only when the senior person is there who knows things will realize there are so many things out of place when you get to the road. There are simple things that I've noticed even now. People don't set alarms on ventilators before starting a case with GA. Many times it will be on factory settings, and if you get into trouble, you will never get out of this. So I emphasize on all my residents that if I'm in the theater, I will set the alarms myself. This is something you just probably ask your residents how often they do all these things. It's very scary, but I have to tell you all these things because this is what is the truth. Because I don't know, somehow it doesn't sink into the PGs that these are all very important. And only people who have worked and seen all these things, we realize every small thing is very important. I keep telling, I was telling somebody in the morning, when I was a senior resident, my tolerance to nonsense was 100%. My tolerance to nonsense now is zero. Because now you realize everything affects a patient.
Yes.
And to that patient, this is 100% if something goes wrong. Because I tell people, it could be somebody's father, it could be somebody's mother, somebody's wife, somebody's husband. For a hospital, it's just a number. But for a family, it is 100% loss. So this is where we have to emphasize patient safety because things we work in an atmosphere where you cannot have control. It's a luxury if you have one consultant to one OT. If that is not there and the volume load is high in places, it is very difficult for one consultant to look after two or three cases. And this is where things are likely to happen because by oversight, you can't keep obviously running around from one OT to another continuously. Even if you are doing it, it's likely the more you run around, the more likely you have possibility of missing something. So I think the only way is have develop checklists. With checklists, you can bring down the errors. That is what I've seen. And but to ensure that these things happen, you have to be in the OT. It's not going to happen if you're sitting in the coffee room and your resident is in the OT. You have to be in the OT, ensure these things are done. I don't know if the surgical safety checklist has been followed uniformly in the country. Still, many places we don't follow that, and that is the first thing that you should start doing because anything that is erroneous, you can get picked up there. Like recently, also we had a wrong patient coming to a different OP. If it had not got picked up, it would have been very serious. But the fact was that it got picked up very quickly because I was there and said, this patient is not supposed to come here. It's a male patient here. Why is a female patient coming to this OT? So it's like you have to look at the OT. You have to look at individual OT. You have to know, at least you have to have that memory of which OT, which patient is there, what sequence. And all these things take effort. Because I don't know if any of us post OT lists in each OT even today. There will be a common list in the OT, and yeah, each OT will run patients one after the other the way they are shifted. It may be a good idea to have the OT list in individual cases so that the people know which OT, which patient is coming after which case. This may appear very, very innocuous, but these are the dangerous times are changeover times. When first shift change to second shift and second shift go to night duty, the dangerous times where people can just slip out. Everybody's in a hurry to leave, and they can just forget to tell something very important. Some of them may realize, go home, call back, and tell us, but other people will just keep quiet. They think, yeah, somebody would notice. I'm telling you all these things because after working for such a long time, these are still things which are happening, and I can only do these corrective measures in my place. Universally, to do all these things, you must have a forum where we have to highlight all these things repeatedly. That every day somebody tells them that they have to do this. That is the only way of ensuring safety in the OTs. Otherwise, errors will keep happening because we have new people coming every day. New people will come, fresh students will come. So, and that is something you can never stop. So we have to be careful, and somebody has to take that extra accountability, pay attention to all these details, because we wake up only when something happens, we analyze it, and then everybody keeps quiet after. It's very difficult to accept the truth sometimes because we will be trying to protect our own colleagues.
The points truly noted, sir. Thank you so much for that. Actually, Murli, sir, I wanted to add just one more thing. I don't know, it's a practice in my institution how we give local infiltration before we do it. So a very important misstep that can happen at this point also is when you have the infiltration and the spinal drug loaded in the same tray. So even that time we have many near misses wherein you grab the wrong syringe and you want to give the intrathecal drug sometimes. So that's also an important when you have different size syringe. One size, the 5 ml is for the local, for the intrathecal, and then the 2 ml is for the infiltration. And then I know certain institutions, like sometimes we give fentanyl, it's 0.5, we give that in a separate syringe. So again, that is also very important to note when you're using tray, because now we've aspirated and nothing is labeled at that point. So be very, like sometimes using the different size syringes also, to note down which one you're injecting at that time. So this is also, a near miss situation that happened. But is there anyone else that would like to add into their experiences?
Very, very rightly said, Archana. See, basically, standardization of spinal, epidural, or regional anesthesia tray is very important. If I keep my hand on the left side of the tray, it is always local infiltration. If I keep my hand on the right side, it is always a spinal or epidural drug. So if you can standardize the tray, it becomes a lot easier because especially if you had a bloody tap and you want to flush with saline, you're creating one more syringe that is added, saline syringe. So you need to be very, very cautious, and standardization is very, very important in the practice.
Great, sir.
Can you just say something?
Yes,
Yeah,
sir.
Manoj.
Sir, please.
Yeah.
The simple solution that I find is once you use the infiltration syringe, don't leave it there. Do it.
I think
Not
Manokant had the
remove it.
same. Manokant had the same comment, sir. Discard
So
the leftover local anesthetic after skin infiltration.
Very
what we do is we infiltrate first and then get the spinal tap, and once the CSF is seen, push the tillet and then load the spinal drug with rule of three, so that it is just loaded and administered. It is not kept on the, it is not preloaded and kept for injection later.
Yeah, yeah, wonderful.
Yes, sir.
So shall we let Abdul kind of take over the stage because he had to.
Yeah.
Abdul, you're here.
Yes,
Thank
sir.
you,
Yeah. Yes, yes.
Archana.
Thank you, sir.
Yeah.
So I have my phone. So
Yeah,
I hope
yeah. So
everybody's.
yeah, a 3-minute exercise.
Yeah.
But 1 minute I'll take just to explain the workflow, understanding the time. So once you have submitted an air log, it goes to a panel of 50 experts from all across the country, from multiple domains: regional anesthesia specialist, cardiac, neuroanesthesiologist, obstetric anesthesiologist, and several other key subspecialty domains. They give their expert opinion on the air log that is being submitted. At the end of the month, all these air logs are then examined by a team of 6 admins from APSA. They develop this newsletter by the end of the month, and you will receive the next newsletter within a few days. So unless you report, you won't have a newsletter. And then if you don't have a newsletter, you won't have these webinars. Without these webinars, we won't have these dialogues. What we want is that not just have these dialogues, but we should have mature dialogues, mature enough to develop our own APSA or India related guidelines as far as patient safety is concerned. That is where we are headed. Every day, I don't believe that in any operation theater, from 2 to 30 operation theaters running in a day, you will not have any incident. It is not possible. I've not seen it happen. It happens every day. Why? Because just like Badrinaran sir just explained, it is multifactorial. You're not working alone. Experience of your technicians, the equipment you're dealing with, the patients you're dealing with, the surgeons you're dealing with, the pressure, the caseloads, and the variety of cases that you're dealing with. It's just not possible that you don't have incidents happening. So my request, take the next 2 minutes. Just open up your apps. There on the bottom, there is a plus sign. If you click on it, you'll see the anesthesia incident report log. Click on it. submit your incident. It can be small, it can be big. Just take the next 2 minutes, submit this, and it makes a huge difference. Last 2 months, we have nearly 120 reported incidents, based on which these newsletters are published, and based on which eventually down the line we'll have our own guidelines. It is very vital that you take part in this exercise. So we'll just take 2 minutes, complete it. And more importantly, what I want to do right now is, because my developing team is behind me for the last 2 months, they want to test the load of the servers that the servers can take while you're using this platform. I cannot have 50 users at the same time, logging on the app at the same time. So we'll just take this opportunity and do this exercise. I hope I don't have to say anything. We'll complete this exercise now. Yeah, the app link is there in the chat at the top, the both for iOS users and for the Android users. You can download the app from there, register yourself. If you're registered, it's easy. You can complete the task in next 1 minute. But if you're not registered, you'll probably need another 2-3 minutes. You can continue doing it after this webinar is completed. But request is that you do it now. All those who have downloaded the app. Once the incident is submitted, you cannot have a look at it. The reason being that we don't want the incident to be traced back to you or your hospital or your city or the patient. We don't capture any patient details anyways, but once you have submitted, you will not have any idea that we will never come to know whether you have submitted your log. No one will come to know that you have submitted it.
Uh,
So
Dr. Nas,
any
let's have a question. In that instance, if you're not,
Hmm.
how do we know that what we've updated has been updated?
Yeah, you'll get two messages. You'll get two notifications saying that it has been submitted successfully.
Okay.
Yeah, and that is the indication. We removed it. Initially, we had this air reference number, but then even that number was deleted later on because we don't want any tracing back to the users.
Okay.
The app link is at the bottom, at the top of the chat.
Yeah, no, I tried it last time and then I didn't get any acknowledgement or anything. That's why I was confused whether it happened or not. That's what
It'll
I want.
happen. Yeah, it'll happen. I'm sharing it again. All right, see, we'll get the notifications. All the reviewers and the admins will get a notification if you submitted. And I request all the users all the webinar attendees that do it every day. If you have in a month 200, 500 incidents reported, it just changes the way we work at APSA. Yes, it is docked app.
There is a question from Dr. Vikram. How can we get the newsletter? Yes, we'll share it on all WhatsApp groups, and shortly we will have it on our website too for people to download. So all the previous newsletters will also be available. The website work is ongoing.
All right, sir. I think we have given 5-10 minutes. Everyone can continue logging.
Yes, I think
Yes.
we can. Yeah.
Yeah.
So, Archana, if there's anything else from your end?
No, sir, that's it. Even I'm trying busy logging. So
Yeah, so everybody can continue logging so that Abdul can see the load. I finished my logging. So we can actually end the meeting and hope to see everyone again back in a fortnight. And I request all of you to share the news that we are having this rounds every fortnightly, and people can log in. Whenever you see the whatever information or the login details, kindly share it with others so that people can join, especially the youngsters, so that we can learn from all the clinical pearls like how Badri sir actually highlighted. So hope to see you all in a fortnight. Thank you for joining. Thank you.
thank you so much. Thank you, everyone.
Good night.
Thank you, sir.
Thank you.